Good evening to all the nephrology residents out there. Today topic is about the topic which I felt very difficult during the beginning of my nephro residency. The transplant immunobiology and the interpretation of the transplant immunobiological reports. When I was doing DM residency, we had very hard time in understanding single antigen bead, the titers, Luminex, what is this flow positive, SAB negative, these kind of things. To solve those problems and to give a clarity to the residents who are in the beginning, first year, second year, who had difficulty in understanding these things, I hope this video might be helpful. In this series, the first video is regarding CDC crossmatch. So what is this CDC crossmatch? CDC is complement dependent cytotoxicity. But before going into that, we'll see one sample report. This is how the CDC report is like. In the above column, you will be having all the basic details. Here it is given as T and B cell cross-match report, complement mediated cytotoxicity with DTT. In the first column, they have given auto cross-match, recipient cells and recipient serum. The report is given as negative. Cross-match with the DTT treatment, donor and recipient. It is given as at 4 degree at room temperature. For T cell it is given as 4 degree and at room temperature. 5 percentage, no other things is written. What is this 5? And final result what they have mentioned, T and B cell cross match negative at both 4 degree and room temperature. Here the photo of the patient and the recipient will be there. So this is how the report is. But before going into the CDC, we will see the things in simple terms. See, there is a donor for the kidney transplant. He is donating the kidney to the recipient. So from donor, kidney is going to him. But what happens? The recipient mount immunological response to attack this kidney. So this is common because the kidney is foreign to the recipient. So what kind of immunological attack can happen? One is blood group mismatch. Suppose if recipient is B positive, donor is A positive, there might be some kind of blood group mismatch can happen. This is regarding ABO incompatibility. This we will see separately. What other thing? HLA, human leukocyte antigen, or major histocompatibility antigen on chromosome 6. This is very important. The antibodies to this antigen might attack the kidney. Grossly, 2 attacks can happen. One to the blood group, one to the HLA antigens. But what is the problem is HLA antigen is present all over the kidney, especially in the blood vessels, vascular endothelium. These HLA antigens are there in the donor. Suppose if this was not checked, suppose if we didn't check the compatibility of the HLA antigen before giving the kidney from the donor to the recipient, what will happen? As soon as the kidney goes to the recipient, it will be attacked and destroyed. That is called as hyperacute rejection. The main motto of the transplant immunobiological test is to find this hyperacute rejection. This hyperacute rejection can occur because of preformed antibody in the donor who is going to receive the kidney. If it is present, it will attack the kidney. It will attack the donated kidney and destroy within 2 to 3 minutes. Within 6 hours it can destroy. It is called as hyperacute rejection. Why it occurs? Because of the antibody to the HLA antigen. This is called as HLA antibody, but the nomenclature is DSA, donor specific antibody. Where is the donor specific antibody present? It is present in the recipient. It is waiting for the kidney to come to his body so that it will start attacking. But the question comes, why the donor specific antibody is present first of all inside the recipient? Probably any past history of blood transfusion might be there during pregnancy or from the environmental things, or right from the birth he might be having some preformed antibodies to attack a particular HLA. So before transplant, our aim is to detect this antibodies so that the rejection won't occur. So let's proceed how we are going to detect this. Before that, with respect to HLA, there are two classes. I hope everyone aware HLA class 1 and class 2. HLA class 1 is expressed on almost all the cells, whereas HLA class 2 is present only in the antigen presenting cells like B cell, macrophages, dendritic cells. So what is the importance of this? In the recipient, we are going to detect the antibody, but we are going to detect what kind of antibody is there, whether it is class 1 antibody which can attack all the cells in the kidney, or only class 2 antibody which will attack only these kind of APCs are there or not. How we are going to do? Since B cell has class 2, B cell have class 2 HLA, and it is a nucleated cell. In almost all the cells of the body, class 1 is there. So B cell have both class 1 and class 2 antigen. If you take T cell, only class 1 will be there. So using this, we are going to detect whether it is class 1 antibody or class 2 antibody. How we are going to do? This is some theory again regarding the HLA antibodies. Preformed antibodies can cause a hyperacute rejection by binding to the HLA antigen in the donor. It activates the complement and causes a massive rejection. And this picture I kept just to show in the kidney, class 1 and class 2 antibodies both might be there. Class 1 is present all over the nucleated cells, whereas class 2 specifically in the antigen presenting cells. Till here it is clear what is our role in the investigation: to detect the antibody in the recipient who is going to receive the kidney, to whom the recipient will be having that antibody. The antibody will attack the donor. So donor, why we are taking T cell and B cell? Because we can't take the entire kidney to detect the reaction. Just we are taking the T cell and B cell from the patient blood, which will act as a marker of HLA class 1, HLA class 1 and 2. So we are having HLA antigen and the donor serum is taken, which contain donor specific antibody or HLA directed antibody. We are going to mix these two and find how much reaction it is going to give. Till here I hope you people are clear. T cell and B cell from the donor we are taking from the peripheral blood. Lymphocyte, basically we are taking the lymphocyte. Why we are taking the lymphocyte? Because HLA1 and HLA2 are present there, which act as an antigen, which is a marker of the HLA1 and 2 which is present in the kidney. So that is why we are taking the blood. Here also in the recipient also we are taking the blood and taking out the serum. Here we are taking out the lymphocyte. Through the various process, the blood is taken out, separated, the lymphocytes are taken. So we will mix it and add complement to it. This is called as complement dependent cytotoxicity. This was first invented in 1960. Basically what we are going to do, we are going to take the recipient serum which contain the donor specific antibody might or might not present. If it is present, it will attack the lymphocytes. Donor lymphocytes are taken, which is T cell and B cell. Why 2 cell? T and B cell, because B cell contain HLA class 2 and class 1, whereas T cell contain only class 1. So after that you add complement. What will happen? If the antigen antibody reaction is there, complement will be activated, the lymphocytes will be destroyed. See, complement is added, it is taken from rabbit, then the classical pathway will get activated, it will lead to the destruction of the cells. Suppose if there is no cell lysis, you look at the microscope, the various physiological or the pathophysiological things involved in this, I am not explaining. Going to the report, suppose if it is negative, there won't be any cell lysis. All lymphocytes are good. Suppose if cells are lysed, that means there is a antigen antibody reaction. What is this percentage? The percentage is given as how much percentage of the lymphocytes are destroyed. If it is less than 5%, well and good, it is normal. If it is more than 20%, that means there is some lethal thread might be there. That means a potent antibody might be sitting. Which kind of antibodies are very important? IgG, because IgM is temporary and it is not that significant. So this is all about the CDC cross match. Now we will see what are all the things possible as per the interpretation. For example, CDC T cell cross match is negative, B cell cross match is negative. That means no donor specific antibody to HLA class 1 or 2. Or it might be present in low titer, or this I will explain in the later half of the slides. Suppose both are positive, that means donor specific antibody is present to class 1 or multiple antibodies to class 1 and 2. Why class 1? Because T cell contain class 1, B cell contain both. So both are positive, that means class 1 is positive. There is a high chance immediately the kidney will go for rejection. So what other combination is possible? Here T cell might be negative, B cell might be positive. This sentence you can leave out. This sentence you can leave out because that will confuse the beginners. If one is negative, B cell is positive. That means donor specific antibody to class 2. Why? For class 1 T cell is negative. B cell contains class 2. So class 2 के लिए there are antibodies. Is it possible to have T cell positive and B cell negative? T cell means HLA1 is positive, B cell is to B cell is negative. Impossible, because B cell also contain HLA class 1. So this is because of some technical error. You have to repeat the investigation. So these are all the various possible combination of the CDC report. So what is this DTT? In the report it was mentioned as DTT. This is dithiotritol. Why it is used? Because IgM is usually not significant. Why it is not significant, we will see in a separate video. The immunoglobulin M, even though it is an antibody, it might form some kind of disulfide bond. It might bind with the antigen and it might activate the complement, but that is not that significant in renal transplant. Immunoglobulin G for Goa, that is important. IgG is very important. But so in order to avoid this IgM, DTT is added. It is some reagent. It breaks the bond in IgM. It prevents the IgM antibody from creating a positive result. So this have no pathological significance in renal transplant IgM antibodies. So DTT is added to prevent these kind of false positive reports. So then the question comes, is CDC is 100% accurate? Should I proceed with the transplant if CDC is negative? Since we are going to do a organ transplant, which is very important for the donor, for the recipient, for the family, financially, we have to double sure, sometimes 3 times sure, 4 times sure, to make sure the hyperacute rejection won't occur. So CDC have its some limitation. That is why flow cross match and single antigen bead assays are available currently to make sure these kind of rejections won't occur. But what are the disadvantages with the CDC? The antibody might be in low titer to cause the complement activation, because without complement activation it can destroy the kidney. That can't be detected by CDC. And the antigen might be in a low amount, very low amount in that particular sample, but it might cause a chronic kind of rejection. Sometimes it might give false positive. If the IgM DTT, it might miss, many a times it might show false positive. And this might not be 100% accurate, because many a times few HLA antibodies might be missed with the CDC. So these are some of the limitations of complement dependent cytotoxicity. Despite all this, T cell cross-match in CDC, if it is positive, that is an absolute contraindication for transplant. You have to change the donor. Why? Class 1 HLA is present in almost all the nucleated cells. If T cell CDC cross-match is positive, that means automatically B cell is positive, because class 1 is positive, class 1 antibody. That means the kidney will definitely go for hyperacute rejection. This is one of the absolute contraindication. You can't proceed further. You have to change the donor. Very, very, very important. CDC T cell cross-match or class 1 cross-match positive is an absolute contraindication for renal transplant. So now coming to the report interpretation. See, T and B cell cross-match report, CDC cross-match, what they have mentioned, complement mediated cytotoxicity with a DTT treatment. Why DTT? To overcome the IgM false positivity. First they have did the auto cross-match. What they have did, they have taken the recipient serum and mix it with recipient lymphocyte. No donor. They are checking how reactive the antibodies are. It is just like a that preliminary investigation in anywhere to show the, it is like correcting the zero error. If these IgM antibodies are negative or positive, if it is positive, that means a high reactivity. This report can't be interpreted. That is why auto cross match is mentioned. One sample they will do with the same patient whether it is reacting or not. It is like checking for zero error. Then coming to the cross match with the DTT, they do at room temperature and at 4 degree. First T cell cross match. What happened? Less than 5% lysis. Less or around 5% cell is being lysed. So that means HLA class 1 ka there is no antibody. B cell cross match at 4 degree at room temperature, it is 5% cells only lysed. What is the reference range they have given is 20% lyse. So 20% lyse of the cell not occurred. So the T and B cell for this donor to the recipient is negative. CDC is negative. That means there is no reaction. That means there is no complement mediated antibody. That means this donor can donate kidney to this recipient as per the CDC report. Because of some of the limitations of this, next we will be proceeding to flow cross match and single antigen bead assays. Currently that is also important. And what is the importance of the cross match? Importance of the flow cross match, importance of CDC, we'll see in the subsequent video. I hope whoever seen the video till the end, you have understood something regarding the CDC, because understanding transplant immunobiology for the first year resident will be very, very difficult. At least if it is helpful to few people, I will make the next video on flow cross match. Bye bye.